Good day, I'm Professor Dr. Lawrence Field. I'm talking to you from my home in New Braunfels, Texas, in the middle of the great pandemic of 2020. As I get older, people frequently ask me what I think is the most important thing that I've done for dermatologic surgery. And there are several. Not just starting it, but a push for better ethics in our subspecialty, critically needed then and now. But the major clinical thing I think I've contributed is to offer a method of anesthesia, which for almost all the body, for dermatologic surgery, other than the middle, center third of the face and deep in the territory of most surgeons, not ordinary dermatologic surgeons, would be bilevel surgical tumescent anesthesia. This has been an evolution of the development of this concept. I first published on this, I first gave a publication or presentation on it in 1996 at the Dr. Hugh Greenway's Superficial Anatomy and Cutaneous Surgery course. That's the first time it was a formal presentation. It wasn't fully developed then, but it was a concept coming out of my work with the anatomists in England, in Newcastle, who displayed heads dissected, arteries, veins, ducts, nerves, all of them in different heads. And as I pondered it, I asked them this question: if we fill the subcutaneous space with a fluid which pushes the skin away from all those nerves and blood vessels and ducts you have demonstrated, is there any place in the face that's a risk to dermatologic surgeons if we stay high? And the answer was no. So I spent now a quarter century since then continuing that. And the work that I've done is now done in many countries. And I tell you, I've had my students, doctors in Indonesia, Germany, Egypt, South Africa, Philippines, Hungary, Portugal, all have the same results. And in the presentation, which I will leave with the ASDS and with DASL and their libraries, will be on the development and usage of bilevel surgical tumescent anesthesia. It is the best method to reduce pain, bleeding, and smoke in your surgeries. So recently, looking at dermatologic surgery, our Bible, here's an article on epinephrine reactions with local anesthesia in Mohs surgery, another one on hyfurcation and interference with cardiac problems. The work with bilevel anesthesia shows that you can use virtually any concentration of anesthesia, and in my opinion, the only risk is major quantities of epinephrine to epinephrine sensitive patients, primarily cardiac, which we essentially never see. We don't see that because these agents are slowly metabolized and removed. So the very usage of this technique virtually excludes any of these problems people keep writing. Month after month after month, we can see these things studied in our literature, when I think the time has come that it's really just largely not necessary. So I urge you all to take a look at that. I know from many doctors, entire countries don't use the anesthesia that I learned as a resident and used in decades of my life. So you'll find all that and elsewhere in The Signal article was published in 2001, November 2001, in Dermatologic Surgery. And from this method of infiltration, we now have another method of trying to determine the depth and extension of malignant tumors. Because working with Dr. Leventer in Bucharest, we came across a patient, and the photos are in the presentation, of a large cancer of the lower lid, where my question was, is it in my province? Or must I get an oculoplastic surgeon to help me, or somebody else, because it was out of my field. So careful infiltration with a blunt infiltrator, not sharp, blunt, and watching where the subcutaneous tsunami wave of fluid lifted the tumor right up. You could watch the tumor come up. Other tumors, as you push your tsunami wave forward, you'll see the fluid bifurcate around the tumor. That gives you the warning that it's probably infiltrated deep and fixed. So it's a useful tool for you in looking at tumors. So I urge you to find the presentation, take some time, look at it, review it for yourselves, and what I think is you'll find it changes your lives. You'll no longer use smoke evacuators. You no longer use methods of taking suction tubes in the wounds. Just won't be necessary unless you're a Mohs surgeon and you're deep and in that kind of fluid area. So thank you much. Good luck with it.